8 o'clock, and welcome to another episode of A Marvelous Medicine. Today's topic is care of the caregiver, which is a oft neglected area in healthcare. Having been a caregiver for more than quarter of a century, I know that my friends and co-workers played a huge role in supporting me in this endeavor. And when you look up online, you get a lot of lists of what caregivers could do, and some things may be as simple as just laugh about something every day, irrespective of how bad the situation is, or allow friends and family to help. Sometimes we think it's our burden, and we should not uh, take help from others, but that's a huge learning that I've had over the past 25 years, that you should give others a chance to help you. Similarly, there's nothing wrong in crying. It's not a sign of weakness. It really helps you to de-stress. What we don't have is so much in India, unlike the West, is support groups for each type of chronic illness, where you could attend those meetings or you could have workshops. So maybe that is something we should look at in the future. And taking a break, like we think that we have to waste all our time, and we don't deserve a break, but that is very important. And we should know our limitations. We think we can just do everything like a superman or a superwoman. So uh, so throwing light on care of caregivers will be Dr. Abhijit Dam. He's the medical director of Koshish hospice in rural Jharkhand. Dr. Dam did his MBBS from RG Kar Medical College, Kolkata, and his MD Anesthesia from All India Institute of Medical Sciences, Delhi. He has done several fellowship certifications in palliative care, interventional pain management. He's also done courses in advanced Vedanta, successful aging, contemplative and end of life care from various parts of the world. He's the national faculty of the Indian Association of Palliative Care, and he's also the president of the National Association of Palliative Care for Ayush and Integrative Medicine. I know that Ayush and Integrative Medicine are not such happy things that modern medicine doctors want to discuss these days, but there is a huge role for uh, for them in palliative care and in caregiving. Special interests obviously are palliative care and end of life care. His Facebook posts on philosophy, religion, and the lost foods of India make really gripping reading. Dr. Abhijit Dam has already done one session with us on palliative care. Welcome again, Abhijit. Moderating it will be Subrato Bhattacharya. He's a family practitioner, Danvers Family Doctors in Massachusetts. He did his MBBS and MS Orthopedics from JIPMER Pondicherry. After that, he did his fellowship in Royal College of Physicians and Surgeons of Glasgow and fellow of the Royal College of Surgeons in Edinburgh. He's a board certified family medicine practitioner in the US. He's a passionate runner and runs marathons all over the globe for social causes. His acerbic wit is evident in his Facebook posts. He has been blogging much before the word blog came into common use, and much before Facebook and Instagram were even conceived. Uh, Subrato has already given us a talk on team building. Welcome again, Subrato. Joining us is a young psychiatrist, Dr. Vasant Ranganathan. He's a consultant psychiatrist at Fortis Malar, Chennai, where I work. He did his MBBS from Mahatma Gandhi Institute in Pondicherry and his MD Psychiatry from Amrita Institute of Medical Sciences, Kochi. He won the Young Psychiatrist Award at Revamp Conference in Taiwan. He contributes in print, electronic, and digital media to spread awareness on mental health. His areas of interest are mood disorders, addiction problems, and stress-related disorders. Welcome, Vasant, to our episode of Marvelous Medicine. Over to you, Abhijit.
Thank you, Dr. Vidya. And I'll just start my screen share. And good evening, all of you, once again. And given the recent times, the times that we are going through, the times of COVID-19, suddenly caregiving, the whole process of caregiving has come once again to the forefront. So we are now looking at caregiving with a fresh perspective, although the perspective would be different from what the classical caregiving is or was. We'll come to that as we go through the whole lecture. Now, after all, you see, we are social creatures, and we do rely on commonalities. You see, commonalities are the factors which bind us together, right? So it was in the month of June, this very month, in 1996, when I first went to the UK to appear for my FRC exams. And the moment I landed at the airport at Heathrow and I walked out, I had this strange feeling of dread. I really don't know why it happened, but then uh, the only thing which comforted me at that point of time was the faces of fellow Indians. I would try to correlate myself with fellow Indians out there. So basically, what I was doing was that I was looking for commonalities so that I could share my feelings or share my vibrations with them. So similarly, there are a few commonalities which all of us go through. The first being suffering, and the second is caregiving. Of course, death is a commonality, but that is a universal phenomenon, like suffering for that matter. Now, Carl Jung had said, only the wounded physician heals. But when the doctor wears his personality like a coat of armor, he has no effect. What he meant was the special character of compassion which we need to develop in our practice. So the reason why I put this slide out here is that the process of caregiving, what a caregiver goes through, we would only get to know what a caregiver goes through or the pains that a caregiver goes through only when we actively go through the process of caregiving. So this is something which I wanted to highlight out here. Now, this is a photograph. I usually leave for the hospital at 7:45 a.m. in the morning. And one fine day when I was getting down to get into my car, I noticed this father with his son. They were waiting downstairs and they wanted to speak to me. So I was in a bit of rush, and so I told them, look, I really don't have the time right now. Why don't you come to the hospital and I'll talk to you out there? But then seeing the state of his young child, I sort of changed my mind and I called them upstairs. And as I was talking to the father, this little child, you see, he gently lay down on his father's lap. And if you can see the peace radiating from his face, that gave me an immense sense of what I would say, peace. That was the point of time where I understood the power of trust and faith. This little child had full trust and faith in his father. So his father was the sort of perfect caregiver for this little child. And this was a very, what I would say, it was a very beautiful, almost a divine sort of a relationship. And that divine aspect of the relationship was brought forward in such a simple teaching for me. So that day, this little episode was a teaching for me. And it opened my eyes to the path of caregiving once again. So as Rosalyn Carter puts it, that there are 4 kinds of people. Those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregiving in the future. So you see, this is again a commonality. You see, all of us at some point of time or the other will have to be involved in the process of caregiving. So there is no escape from it. And if there is no escape from it, it is best that we accept it and be very good at it. So this out here shows another aspect of caregiving, the mother with her mentally retarded child out here. The caregiving process goes on here as well. And here is another aspect of caregiving. We were actually distributing clothes in a village. And at this point of time, we were distributing saris, So you can see the women folk are actually standing in a queue out there. And this particular lady, I'm putting there, oh yeah, she's the mother. And these two are the children. And this is the wayward father, who was a drunkard basically. So because the mother had to suddenly stand in the queue to get those saris, she had no option but to give both the children in the lap of the father. The father had no option but his hands were literally full. There was no way that he could run away. So he was suddenly burdened with both the children, So this was something new for him. Caregiving is something like that. You don't expect, or you won't expect that suddenly someday you might have to become a caregiver. You don't really become a caregiver by choice. Sometimes it is thrust upon you, like in this circumstance, where the father suddenly had to be the caregiver, albeit for a short period of time. So it was something very new for him. And here is another example of caregiving: a single mother with her child who was physically and mentally challenged since birth, with a tracheostomy and a gastrostomy in situ. So this was another facet of caregiving. So if you actually put yourself in the shoes of these heroes, I prefer to call them heroes, you would understand the huge facet, huge area which caregiving actually covers. So if you ponder as to who actually is a caregiver, a person attending to the holistic needs. When you mean holistic, you mean the physical, the psychological, the social, as well as the cultural needs of a dependent while managing their own life affairs. So this is the twist. While managing their own life affairs, you have to attend to the holistic needs of a dependent. Now you might argue that, yeah, a mother is a caregiver for a child. But then if you see the process of care relationship between a mother and a child, or a father and his child, that process is associated with hope and an expectant future. But when you become a caregiver of a situation where the patient has a terminal illness or a very short period of life left, then the whole relationship changes. It becomes more of a core rather than a pleasure to do caregiving, because at some point there is an element of suffering, because you know that at some point of time the patient is no longer going to be with you, that your loved one, whom you call the patient at this point of time, would not be with you for a very long time. So that is the difference between caregiving on a long-term basis and the caregiving that a mother or a parent does for their children. So is it a job? Maybe. And we are promoting caregiving as a job. And I do believe that in the coming decade, caregiving in India would come up to be a big job front. Although not a very glamorous one currently, but then caregivers are actually scanty in India. Trained caregivers, you really have to take a torch and look for them. It is that rare. So who are the caregivers in India? Families provide for more than 80% of the caregiving process globally. And more than 75% of the caregivers are women. Whether they like it or not, it doesn't really matter. It is literally thrust upon them. And that is not true only in urban areas. If you even in the rural areas where I practice, You can see this little girl, I would call her the little lady, is the forced caregiver of a little sister because both the parents have gone to the fields. So this is another facet of caregiving. But this facet of caregiving is not exactly comparable with the caregiving, with the long-term caregiving of a disabled or a terminally ill patient. And here is another facet of caregiving. Although this facet, this beautiful facet of caregiving is rapidly disappearing from India because of nuclear families. In the erstwhile times where we had this beautiful joint family system, some of which still exists in villages, the little children would act as caregivers for the elders. And this was another aspect of caregiving, which I found to be so beautiful and divine. It actually taught me a big lesson. We do home-to-home visits for the rural elderly in the area where I practice. And there was this lady, she was more than 100 years old at that point of time. And her caregivers were actually the livestock, that hen with her chicks, and there would be a goat coming in, and there would be a dog lying down in the same room. They used to sit there and give her company. That was another facet of caregiving, because you would argue that how can a hen actually be a caregiver? I would argue, yeah, a hen can be a caregiver because that hen with her chicks provided some psychological support to her. It was spiritual for her because the presence of those livestock gave her a sense of meaning and purpose in life. And as that old woman would eat that morsels of rice, she would drop some on the floor so that these animals and birds could actually come and share the food with her. So as I said, this little room at that point radiated divinity. And if you wonder if there is God or not, I would argue and say, yeah, that definitely is God, and this is God. And then there was this photograph depicts another painful aspect of caregiving. This is a couple, that elderly man and his wife. The wife is sitting on the charpoy. And the people who are in the background, those are just onlookers. They have nothing to do with this family. It is only when we went for a visit to this family that these onlookers came to pose for the photographs and all. Now, this elderly man used to take care of his bedridden wife. His wife is, at that point of time, she couldn't walk. And then this elderly man became blind. So he could not take his wife because he couldn't see, So he couldn't help his wife to go to the washroom. So the wife used to sit on that charpoy. You see, the charpoy has those holes out there. And she used to just lift her sari and relieve herself from the same charpoy, because they had nobody else to support them. And this is another glaring example of how important a caregiver is. Caregivers, have you ever wondered who would actually take care of you when you are no longer physically active? Have you ever wondered? Your children, do you expect it from your children? Or have you done the same for your parents? So who exactly is going to take care of you when you are bedridden? And what plans do you have, or have you made any plans to address that issue? Because studies have shown that on an average, if we die from old age, on an average, an elderly person spends at least 2 years, 2 complete years, he has to be dependent on others for his daily needs. So 2 years of physical dependency, and who exactly is going to take care of it? And how do you address this problem? Think about it. So what are the common tasks that a caregiver has to undergo? See, as I said, you don't become a caregiver by choice unless you take it up as a profession, which we at our hospice are promoting right now. But otherwise, most of the caregivers are forced caregivers. It is thrust upon them. So the physical tasks like bathing, dressing, feeding, turning, I am actually doing these tasks for my bedridden father now. Actually, today I spent more than 1 hour just giving back care, cleaning him up, changing the bed sheets. It took me 1 hour and a few assistants. It's that difficult and it's that time consuming. Then there will be practical needs like shopping, cooking, washing, bills to be paid, legalities, etc. And then there are emotional needs also of the bedridden patient, which you need to address, like companionship, support, right? So these are so many facets of jobs that a caregiver has to perform. And in addition, the caregiver has his or her own life, their own needs, right? Their families or their own problems or jobs which needs to be attended to. Like, especially as I said, more than 75% of the caregivers are women, and the woman has to cook. If you see a rural woman, she has to cook in a this chula, this type of a chula, and she has to get firewood for that, and then attend to the cattle, clean up the whole house. It's a mammoth job. So you would argue, what should be the characteristics of an ideal caregiver? The caregiver should be compassionate, agreed, caring, unselfish, focused, protecting, loving, very well. What I say is that it is not necessary that you have to fulfill all this criteria. It is good to be selfish at times. It is okay to say no, because unless you can fill up your glass with love, you cannot pour out love for others. You need to fill up your own glass with water before you can give water to others. So you come the foremost. If you are physically well, only then you can provide caregiving for that dependent person. So all these criteria might be very good, theoretical criteria. But when it comes to practicality, first take care of yourself. Culturally, there is this classic in the Hindu mythology. There are this classic story of Shravan Kumar, who took his blind parents, and in the process he was killed as well. So we aim for perfection, definitely. These should be our very classic goals, but always these goals cannot be achievable. These could be the ideal things. We should follow the ideal path, but then first take care of yourself. Feeding. This feeding an elderly especially takes a lot of time. It can take close to an hour to feed an elderly. They are worse than children. And especially if you are changing the texture of food, say you are giving a solid roti, you are giving a chapati with sabji, and then suddenly after one bite of chapati and sabji, you change it to porridge, there is a chance that the elderly might aspirate, because the brain of the elderly is now accustomed to the solid feel of that chapati with the sabji. And suddenly, without telling the elderly that now I'm going to give you some porridge, whose consistency is totally different. If you just thrust that teaspoon of porridge in the mouth of the elderly, the brain takes time to adjust to that. So you need to give them time. And this is how most of the elderly aspirate. So feeding is by itself the process of cooking. First you have to cook the food, and then you have to feed them. Cooking can take an hour, and feeding will take another good part of an hour. And all this whole process of caregiving can lead to a lot of stress. Studies have shown that caregivers have a higher prevalence of osteoarthritis, hypertension, obesity, activity limitation. They are at increased risk of poor physical and psychological health outcomes. And time devoted to caregiving can affect your financial stability because you can't go out for jobs, or maybe you'll have to take day offs, reduced employment opportunities, availability, your time for availability of your other relationships, like with your friends or with your fiance or with your wife or whatever, that is reduced. So there is basically a role captivity. The caregiver feels that I am actually stuck. I am stuck. This feeling of being stuck is something which we call a role captivity. To break the chain at a particular point of time. As I said, we at our center, we started with the first batch of palliative nursing aids for the rural women as a part of empowerment of the rural women. So 10 students passed out in the first batch. And you see, we were here teaching them how to change the dress of a incapacitated patient. And you see how many people, how many students are actually struggling to just help the patient put on his clothing. See how many people are actually struggling. So unless you do it yourself with an incapacitated patient, you won't realize how tough it is. How tough it is. And this COVID times, there was something which I prefer calling fast tracking of the process of caregiving. Nobody, as I said, becomes a caregiver by choice. In the COVID times also, people were forced to become caregivers. And what was different about the whole process of caregiving in COVID situation was that you became a caregiver with the hope that the patient will become better, right? You were not looking at long-term caregiving. So you basically went with a clear mind that my patient might recover, there's a high chance of recovery, and that the process of caregiving will not be of infection both ways, which was potentially, there was a high potential of mortality, right? So there was a chance that the caregiver would contact the infection. And it has happened so many times where the patient survived and the caregiver caught the infection and the caregiver passed away. There were social, cultural, and regulatory issues, loneliness. Like our hospital, which is a COVID hospital, our hospital had COVID, right? So that was the way, at least they could interact with the patients, they could interact with the neighboring caregivers also. So that talking and sort of trying to normalize things was very important. They were not able to grapple with the changing trends, like pulse oximeters suddenly jumped into the market. People didn't know what they were, and they were fascinated by the device. There was something very new for the general public. Oxygen cylinders and the whole concept of oxygen suddenly came into the limelight. Drugs, daily new recommendations would come forward, and the caregivers would also keep struggling. Excuse me. And then there was this profiteers from the epidemic. There was a huge black market which emerged very rapidly. So there were financial issues also. And almost 100% of the caregivers were the family members. And here too, if you see in this photograph, that is the father-in-law who is lying down. He has a high flow device, high flow nasal oxygenation going on. He's COVID positive. And that caregiver is his daughter-in-law. You see, from the whole household, the daughter-in-law was nominated to go and stay with the father-in-law. Now, whether she liked it or not was a totally different issue. Nobody even bothered to, ask her opinion about it. And you can see the chair out there, and she must have been spending sleepless nights sitting on that chair. So you see how difficult the whole process of caregiving had become. But the difference in this process of caregiving was that we understood that this process of caregiving was short. And I mean, if you compare it with caregiving of a person who is, say, paralyzed or, terminally ill, where you really don't know how long it would linger. But here, more or less, you had a idea or a time frame that may be a week or maximum 10 days. So that sort of conditioned your mind to approach the process of caregiving in a different manner. But what made COVID different was that the caregivers were scared for their own lives, because there was the potential of transmission of infection. So this thing made the whole process of caregiving in COVID situations very unique. And then once you start the process of caregiving, the patient healer archetype kicks in. It is unavoidable. Right? Now I'm the caregiver for my bedridden father. So there is something called transference and counter transference going on. So my father views me as his son naturally. So he sees me as his little child, and he feels that, yeah, whatever I say, my child will do it. And he looks at me from that angle. He doesn't look at me from the angle of that my son is also a doctor. So he doesn't consider me that way. Right? So he considers me his little son, and the son is doing his job. So that is transference. And counter transference is what I transfer onto the patient. Say, if I have had a very congenial relationship with my father, then it would be a nice, friendly relationship or a counter transference which I can transfer to my father, my vibrations, my vibes, as you call it, to my father. But if I have had a bad relationship with my father, then I would be transferring my anger, my frustration, my aggression to my father consciously or unconsciously. Right? So this process of transference and counter transference does happen in the process of caregiving, whether you like it or not. And all this given together, all this which we have talked about over the period of time gives rise to what we call the caregiver burnout, where the whole process of even thinking about the process of caregiving brings in a sense of dread, tension, irritability, anger, fatigue, right? So this is often a precursor to a major depressive disorder. And this is something which has to be tackled early and very aggressively. So there is something called compassion fatigue, when you are tired of being the goody-goody person, right? So if you, I'll just give you a small example from Vedanta. There is something called the Triguna. There are three gunas. There is Sattva gun, Rajogun, and Tamogun. All the three, we are a mixture of three gunas. So if you say that this person is Sattvic, that he has Satogun, Sattvic person means he is very good, like the typical Brahmanical qualities are there in him. So no person can be totally Sattvic. Even the most decent person will have some amount of Rajasic and some amount of Tamasic gun in it. No person can be absolutely pure, right? So compassion fatigue is something of that sort. You start the process of caregiving with a duty, with a devotion, with some compassion. But over that period of time, that compassion sort of starts wearing out. So there is a diminished emotional energy needed to care for patients or others. So what are the symptoms of this compassion fatigue? There can be hyperarousal, like disturbed sleep, irritability, sudden outbursts of anger at almost nothing at all. Then avoidance. The very thought of having to go and change the diapers or clean up the fecal matter would, bring in a sort of avoidance. And then there is re-experiencing, like intrusive thoughts or dreams and psychological distress in response to reminders of work. Because your mind, this monkey out here, will not sit still. It will keep on harassing you. Even when you're lying down quietly on your bed at night, your mind will keep on repeating playback of those episodes will be happening in your mind, and you'll keep on responding to those episodes again and again. So this is a vicious cycle. This re-experiencing is very distressing. So who are actually prone to this compassion fatigue? Especially those who have unresolved past pain, past trauma, or who have had a bad relationship with the patient in the past, um, or people with an overdeveloped sense of responsibility, like the classical daughter-in-law, which I showed you in that COVID photograph. She was chosen to do the caregiving, and she readily volunteered because she felt that, yeah, me being the daughter-in-law, it is my sense of responsibility. So this overdeveloped sense of responsibility, an impulse to rescue anyone in need, lack of strong personal boundaries because they don't know how to say no. They cannot say that, no, I need time to sleep, please don't disturb me. They cannot say that. And if you cannot stand up and fight for your own self, then definitely you will experience compassion fatigue. There is no way you can avoid it. It is often that during periods of intense physical and psychological suffering that an individual takes recourse to religion and spirituality in order to help transcend suffering and bring about a sense of meaning. See, this is where spirituality and religiosity come in very handy. And this I speak from personal experience as well. And these little temples or masjids or churches or gurdwaras, I call them places of research. These are not simple temples. These are places of active scientific research, because you go there with a questioning mind, and most of your answers come from those places. When you sit in solitude, spend time with yourself, and when you seek answers, the answers gradually come to you. Suffering seeks validation to blossom positively. Remember that. All of us suffer. All of us suffer. There is nobody, as I said, suffering is a commonality. There is nobody out here who are now out of the 50 participants now, which I see, I bet there is no one who has not suffered. So that's a commonality which binds us. But our suffering needs to be validated. There should be somebody who comes and acknowledges our suffering. Only when our suffering is acknowledged, it is validated, that it blossoms positively, that we can transcend our suffering and make a sense of meaning and purpose out of our suffering. That is important. So what are the benefits of caregiving? It can reconnect or strengthen the relationship. Having a poor relationship with your parent maybe, and then when your parent falls sick, and then you again sort of reconnect and bring back that, bring back a rewarding sort of relationship with your parent or whoever you're taking care of. It can be personally rewarding because you feel that, yes, today I have done something. Today I've done, although you might be spending, say, a couple of hours out there in the process of caregiving, but at the end of the day, you feel good within. That is more important. It can help boost your own self-esteem, because if you are true to yourself, that is what matters. It allows care recipient to enjoy individualist attention at home. Now, the question is whether you would rather put your patient in a hospital or take care of the person at home. So it's a very tricky question. Just ask yourself the same thing. If you were in this place, where would you like to be? At home or at a hospital? And you will get the answer. And just do that. And here is another example, this daughter-in-law, and that is the father-in-law. Father-in-law dying of terminal cancer. and the daughter-in-law and father-in-law never had a very good relationship before. But once the daughter-in-law became the caregiver, primary caregiver of the father-in-law, their relationship blossomed positively. So this was a very positive effect of the process of caregiving. And then, as Stuckey said, there is something called the reconciled life perspective. Right? So all these adverse events, like the process of caregiving, as I said, caregiving is literally thrust upon you. So you need to reconcile your suffering. You need to give it a sense of meaning and purpose. So often spirituality and religiosity helps a lot to give your suffering a sense of meaning and purpose, which is very important. So this was a study which was published in the Journal of Religion and Health. What they did was religion and caregiving for orphans and vulnerable children, a qualitative study of caregivers across 4 different religious traditions in 5 global areas. So what they found was the respondents discussed how religion provided a strong motivation for their work. You see, they were just caregivers who were looking after orphans. So, but they found that religion provided a strong motivation for their work, reported that religious institutions were often the way in which they were introduced to caregiving as an occupation. How many of us actually think that caregiving can be an occupation? We really don't look upon caregiving as an occupation. We look at it upon as a forced duty. It is not that. It can be an occupation, right? And they spoke of the ways religious practices sustain them in their work. Like religious practices can give you that motivation to go forward in the job of caregiving. And then there is something called the butterfly effect of caring. You need to learn to be sensitive, non-judgmental, and respectful towards yourself. So as I said, first, fill up your own glass with love. And only then you can be sensitive, non-judgmental, and respectful towards others. So this is what we call the butterfly effect of caring. So again, as I said, religion has a very positive way in which it provides not only a moral code of conduct for the process of caregiving, like I gave you that example in which that Shravan Kumar was taking his parents in the dolly. Right? So it can influence the way individuals evaluate, restore, and preserve the quality of relationships with each other. Right? So this is what in the Vedanta, in Hinduism, it is called the Dharma Shastras. The Dharma Shastras basically lay down the principles by which one has to conduct themselves in the society. And self-compassion needs to be practiced. I won't go into the details of self-compassion here because it's a lecture by itself. And mindfulness also. You need to really bring your mind back and focus on what is happening in the present. Right? So this again itself is a lecture by itself. So another example of caregiving where the whole family is actually participating in the process of caregiving. So this way, this model of caregiving where the whole family is participating is very much desirable because the whole burden of caregiving is shared by different persons of the family. This is what caregiving should be like actually. So the road to healing of the caregivers. Physical removal is the most important thing. You need a break. You actually need a break. So physical removal from the process of caregiving, you take a break for 3 days or a week or whatever. Let somebody fill in the gap for you. So the first step is the most important and the most difficult step because nobody would volunteer to fill in your gap. So basically, it is very difficult for you to take a physical break, physical removal from there. Right? And then there are other things like, asking for help is very important. Asking for help. There is no shame in asking for help. Please ask somebody to fill in a gap, or please ask somebody, can you help me with this? And to be grateful. Like in Reiki practice, practicing gratefulness is a very important part of the whole process of Reiki. And I see that practicing, if you practice being grateful, life becomes so much easier for you because you are the most important person in your life. Have you ever realized that if you are there, only then your world exists? If you cease to exist, the world ceases to exist because you are the world, isn't it? When you go to sleep, your world ceases to exist for you. And when you are awake, your world comes back to you again. So you are the world. Think about it. So the caregiver is as important as the patient. And caregiver often endures more suffering than the patient. So you need to acknowledge the suffering of the caregiver. As I said, suffering needs validation to blossom. You need to validate the suffering, validate the stress that the caregiver is undergoing. Listen, listen, listen. Active, empathetic listening. Support. Sadly, in India, we don't have the support groups or the support systems. I mean, this is the need of the day, actually. And after this COVID pandemic, this is what is needed. We need to generate support groups, right? Respite care, as I said, you need to take a break. You need to have a physical removal from the situation. So respite care is very important. And then psychological interventions are there, like CBT and psychoeducational interventions. These look good on theory as far as India is concerned, because if you actually go down to the grassroots levels, if you go down to small towns and villages, these things are unheard of. And the caregivers continue to suffer. So would you like to be a caregiver once again? Thank you.
Thank you very much, Dr. Dam. If you could stop sharing your screen, and over to you, Patta.
Dr. Dam, that was just a wonderful presentation because this is such a large topic. There are so many things to talk about. And you pretty much covered every little bit of it. And I absolutely love the personal examples and the pictures that you got to us. I mean, it shows a side of what you know caregiving at the grassroots really is. You also said something in this excellent lecture. You said something that really resonated with me. Fill up your cup with love. I lost a dear friend in 2015 to pancreatic cancer, and it just destroyed me watching her die because it got me depressed and I did not recognize it. So I started running in tribute to people, and I listened to this group called the Grateful Dead when I run. I like their music, I enjoy their performances, I like seeing their live performances. And one of their songs, Ripple, has a wonderful paragraph to it, and that is, reach out your hand if your cup is empty. If your cup is full, let it be filled again. And that is the motto I put on my race shirts when I run. One of the things medical school does not teach us, or at least did not when I was a student in 1975, was we became great at disease. We did not become good with people. And when I finished, when we did the Hippocratic Oath, which said, primum non nocere, first of all, do no harm. What I did not recognize was it's not just not doing harm to the patients or the people you serve. You got to recognize you are human yourself. And you could put yourself into harm if you don't recognize what you're dealing with. Because what we have in medicine is the finest seats in the house to human misery. Every day we see people who suffer. Nobody comes to the doctor and tells you, I came to you because I was feeling great. I thought I'd just stop by and say hello. Nobody does that. We see humans suffering all times long. there is but not much of a scope to learn how to deal with this. Some of us just have the personalities to deal with it, some of us don't. We are all bright. That's how we are in medical school. But it doesn't mean we have the personalities to be what a caregiver or to be what a listener or to be what the orchestra and not the main singer has to be. At all times, you got to recognize the diva or the person who is the main performer is the patient or the person you're caring for. Our roles, no matter how talented, is a step behind. I mean, essentially, as a caregiver, especially for terminal illness, and that is why I brought up the topic of COVID before we even started. So many people were thrust into the role of walking the last miles with their loved ones until they turned their back to them for the final time. And there are so many things that are unsaid, undone. No, there is not much of training that is there that is for this. There are two kinds of cultures in the world. There are subjective cultures and there are objective cultures. In a subjective culture, you create your fate. You are the subject. Your life has been given to you and you do what you want. You have the independence of thought action to do this. In an objective culture, you are the object of what life has created. You live out your karma. And in Hindu religion, it is from because of a past life, you're living this out. Many things in India become part of an objective culture. It is seen that your role that is there is part of it. The part of the culture which sometimes makes what you're saying a little difficult to do, which is, you said, you have to seek for help, learn how to ask for help. That is difficult to do because in addition to being an objective culture, we are also a shame culture. You are shamed into behaving the way the collective group wants to do. Example, when I was a kid, I was the most mischievous kid. Nobody ever came and told me, you made this wrong. They would go and talk to my parents. You know, that son of yours is just not good enough. So the shame is brought to you with a collective feeling around you that, you have to conform. And once that is there, it is difficult to ask for help in a shame culture. But by the same count, India has got something that makes it wonderful for being a caregiver. What is that? As a culture, we do not know how to say no. Nobody says, I will not do this. They will say, I will try, I will adjust, maybe I can do it. You understand that it means no, but we are not directly confrontational in saying no. So I think sometimes what happens is we have to look at the different models in the light of who we are and what we must become to become caregivers. And I think you summed that up beautifully. Patience, patience, patience. That is the most important thing, to recognize it is all about the person you're caring for, and you have to be incredibly patient. To recognize that you don't have to be perfect to do this, that you can break down, that it's okay, that you can hurt, and it's all right to step back and acknowledge it. Because one of the things that's not addressed much, I think, in the Indian setting, and I might be a little wrong, and if I am, just please correct me, is that the caregiver is the one that is left after the person passes on. And you may end up with post-traumatic stress and recollections of that people don't recognize. People, when I come to you and I tell you a story, my story is the collective pieces of all of the things that I've experienced in the past. And if you've had a not so good experience being a caregiver, that itself might lead on to stress. And should you be asked to be a caregiver again, you have to first come to terms with that to do that. I think some people are just naturally talented at being this, others are not. I don't know how one teaches this. I do not know whether this is a teachable skill. I don't know whether kindness is a teachable skill. We may be able to fake it, but I don't know if it's I mean, if you enjoy torturing small furry animals as a child, you'll probably end up as a lab researcher. You will continue to do that. You cannot be, a zookeeper. So I don't know what one does to do that, but I think discussing these kind of things in a medical setting is absolutely vital. The younger doctors need to hear this. The younger doctors need to know that if you don't look after yourself, your own health, recognize you're only mortal, it does not bode well for the future. Not all of life and medicine is disease alone. It is people. We may be doctors, but we are people first. And to recognize that is a big thing. But all that said, this is an excellent presentation. I am so impressed by the fact that you are doing this work for palliative care, because that is such a needed thing in life, not just in India, all over the world. As a human being, to be able to have support when you say your final goodbye is the best thing that anybody can have. So thank you for that.
Over to you, Vasant. We'd like to hear from you. Please unmute yourself.
Yes, ma'am. Thank you, sir. It was an excellent talk. And yes, as a psychiatrist, we do see a lot of caregiver burden. In a way, how it is different in our setting is you were talking about hierarchy, like the son taking care of the father or the daughter-in-law taking care of the father-in-law. But in psychiatry, yeah, when I talk about mood disorders or when I talk about schizophrenia, these are disorders which are chronic. It isn't that they come and within 3 years it's all fatafat done and they're bang on. No, the parents become caregivers by de facto, and not only through their lifespan, but they'll have to think about after them what does the child do, because psychiatric morbidity does not reduce a lifespan, but the care is always required throughout this journey. And in that way, one aspect, yes, when we talk about dementia, that is a total different aspect, that is old age, and the next in family comes and takes care, and that's a different set of things that they feel through. But this is another angle wherein the caregiver necessarily does not be the younger one. I've had patients who are like 50-year-old for the past 20-30 years with diagnosis of bipolar affective disorder on medications, and their caregiver for each flare-up of manic episode or a depressive episode is their 70-year-old parents. And when they turn up to the OPD, they are in more distress than the child, because they have seen it all. They have seen through all the episodes. Like in my practice, probably I would have seen 10 episodes of that patient, but his whole life, that parents have been there, and they have been through him through all the things that he shows. And one more thing that is very different here when it comes to psychiatry is the patient invariably is not aware of what he or she is doing. If he is in a manic spell and he goes about spending 3-4 lakhs per month or per day, like I had a patient whose father had retired. He put up all his savings from his government income, and unfortunately a month after his retirement, after the PF and all had come, the son went into a manic spell. He's gone into a luxurious store, bought saris and dresses for all the people who work there, using his father's credit card. And gone. What the father had thought is going to be his journey for the rest of his post-retirement life, the money that he had saved, is just vanished into thin air. Now he cannot go begging back all the saris and gifts that this guy has gone and distributed all over town. So that way, and there is no point in talking to the patient, because the father recognizes that this guy has stopped his medicines and now he is in a full-blown place. In the next place, I have to go visit the psychiatrist. So many a times, not only the stress of being a caregiver, but also the burden of managing that patient throughout. That is very evident, or that's what I see in my practice as a psychiatrist, which is a little different from palliative care of cancer patients or other terminal illnesses, where the patient at least has a gratitude for that patient, for the caregiver. He says, I've been so mean to you so long, but now you're taking such good care of me. I wish I could have done something good. But those words will never come out of these patients, because they don't know what they are doing. So it is, as you said, it is the forced caregiver. Because you are my son, I have to take care of you. That is, so that brings in a lot of more burden and thing. So whenever we see patients of diagnosis of chronicity in patients, we make it a point that we assess the caregiver burden through an inventory or through an interview or a simple 10 minutes stop after the patient has spoken, as to find out what he or she is doing. How are they managing? What do they cope up with? What is their defense mechanisms, or what are their coping strategies that they have adopted to manage him? And one more thing is the stigma associated with it. Like you said, take time, make sure to ask for help, or create a group. I remember around 7 years back, when we thought about having a family group of patients with schizophrenia, young patients who are fully psychotic, so the parents can form a group and discuss as to how. You would be surprised. Many of them said, "No, sir, I don't want to come out. I live in this neighborhood. I don't want my neighbor to know that this is here. What if somebody who comes over to the support group is my relative?" And educating them that this is actually helpful was a big task, because they were more worried about the stigma associated with it and being identified in the open, like, oh, this is his son has got this diagnosis and is under a treatment for a mental illness. So that was more disturbing for them than managing this patient on their own. So that is another very important point from a psychiatrist's perspective that I feel the caregiver undergoes. And as Subrata sir was saying, uh, post the event of caregiving, when they actually face death, we see the caregivers come back to us with a lot of guilt. Was something that what I did, did the life end, or was my caregiving not enough or not adequate that he couldn't make through? So and they start going into that phase of denial and anger, and there's a cycle of grief. And many a times when they're depressed, they get all this feelings of guilt, ideas of hopelessness, feeling that am I the reason that he left? And they forget to see the larger picture of how good caregiver they were, and because of their help that he was able to push through these many years. And it has nothing to do with and invariably it happens, as sir was saying, aspiration or something. I gave him that morsel of food and he aspirated, so was that the reason? So many a times this guilt and the other PTSD kind of picture that presents for caregivers even after they have finished their role of as a caregiver, so it continues with them. So these were the few points that I wanted to add as how different a caregiver is from a psychiatry department and from a psychiatrist perspective.
Thanks, Vasant. We have Dr. Dinesh Naik, a neurologist, also logged in, and the neurologist and neuro times we have to discharge the patient before they are actually fully all right, or there may be something like epilepsy which starts in childhood and goes on forever. So, Dr. Dinesh Naik, your perspective on caregivers for neurological problems.
Thank you so much, ma'am. And it was such a wonderful, mesmerizing program. And Dr. Dam was absolutely brilliant in his exposition of real-time, wonderful definition and of caregiving, and how the real-time problems that is associated with caregivers and looking after patients and people who are in their terminal life, as well as for the shorter term, like, for example, the COVID. Yeah, I mean, I think as neurologists, we come across, some very difficult conditions. Most neurological conditions are, many of them are degenerative neurology. Many of them have got neuropsychiatric manifestations. And as we are now, aging, the aging population is increasing in our country. People are living longer, and they have a lot of neurological comorbidities. And of course, and then the other end of the spectrum, as a neurologist who's interested in looking after patients with epilepsy, and there's a huge chunk of patients who have got, mild or moderate mental retardation, autistic spectrum disorders, along with epilepsy. And, the caregiving in those settings can be very, very challenging. And looking after a child who's got, something like autism and or autistic spectrum disorder, various degrees of that, severe behavioral issues, and then they also have severe epilepsies, and that combination is something terrible for parents. They go through real difficult times. Parenting itself is a caregiving, but they have hope. But the problem with these children, looking after an autistic child with bad epilepsy or refractory epilepsies, without autism. I mean, they're just otherwise normal, but a child who's or a boy or a girl who's just falling down every day and injuring can be terrible. And all the hopes that parents have in their children of a good and a bright future, and so caregiving, which is actually usually a very pleasant exercise for parents, becomes a massive burden, and there's no end to it because they can't see a fruition to their efforts. And I think that is what I come across quite frequently because I deal with drug-resistant epilepsies. And so I see a lot of parents who have these issues, and I can just the only thing that I do is to encourage them as much as possible, try and improve the children's behavioral issues as well as their epilepsy. And in a significant proportion of them, I mean, all they need is when they come to the clinic, apart from the treatment, adjusting the medication or whatever it is, spending about 15 to 20 minutes just talking about different things. I mean, that itself is a big relief for them. And then empathizing with their problems of looking after and all that. And I think as we are caregivers to our patients, so I would look at it. Caregiving is in a much broader way. We are not just rolling out medicines, but we are also actually caring for patients as doctors. And if we also take that role and look at us as caregivers ourselves, then we start becoming, the dimension changes a bit, and you become part of them to a large degree, and of course that's time consuming, and it's also quite emotionally quite challenging. And but nevertheless, it's very, very fruitful. And then the parents and the caregivers themselves, they start looking at us also as pillars of support. And if you're able to provide that, that eases their burden to a large extent. And that's what I've found. And this has been my experience. So I spend a lot of time, apart from the medical issue, which actually generally is not that difficult to handle actually. But I find that, the psychological issues, the parental or the caregiver burden, and their anxieties and their stresses and their uncertainty which they have. And if you try to say what I do is, okay, let's see over the next 3 months what's going to happen. I'll set them a goal. Okay, this child, I'll try and improve the child's behavior to this extent. Now you start doing this and that. I'll control the seizures. You give them a little bit of that positivity and that hope, and then they look forward to those 3 months. I mean, that's the way in which you can actually build trust. And when it actually happens, they feel grateful, and a little bit of their burden comes down. That's the kind of partnership that I've been adopting, and I think it's working pretty well. But I can fully empathize. I look at myself as a caregiver to my patients, as well as to the caregivers themselves as a community. Thank you very much. That's my viewpoint.
Thank you, Dr. Dinesh. Nalla has been a caregiver for several years. So, Nalla, do you have any tips for those who are in a situation similar to you? And if you have any comments on what Dr. Dam said, go ahead.
Thanks, Vidya. As usual, a wonderful evening and a wonderful topic to pick on. I had just messaged a lot about caregiving, and I always said it's of two types. One is the parents, as previous doctor, our neurologist said. When you have a child who is born with cerebral palsy, Down syndrome, autism, which develops later, that caregiving becomes for life. And the persons who are involved are only the parents, the mother and the father. When a caregiving comes later part in the life, that's when the mother becomes at 80 or 70, dementia with a lot of, or with a terminal cancer, that caregiving becomes a different part. The caregiving that starts at birth is a very stressful caregiving. That's what I wanted to express. It's a stress for the family, and there have been a lot of incidences that has happened is that invariably the family departs. There is a divorce in the family, which is sad. And either of them just take away because the stress is too much. So we have been looking at a lot of counseling and things to keep this going on as far as possible in a better way. So I would suggest that caregiving should be more focused on two things. One is to keep the person who's giving the caregiving also to be comfortable and, at a brain state of taking all the stress, and to relieve them up. I would suggest that we used to have breaks. Like we have vacation breaks where the children are taken away, the parents are given off for a month or so. This is done by the NGO organizations in Dubai, where they come and they take the children out in a group, and then they take them away so that the parents can get away. So things like this can always help to de-stress the caregivers. And I feel economic, it plays a financial aspect is a very important role in caregiving, because either way, whether it is from the beginning or in the middle or in the later part, whether you employ a caregiver to come and personally do it or you take care of them, underdeveloped and developing countries are far behind, whereas the developed countries can take them off. They have people they have centers, they have people who do all this facility. But I think the concept is that there's a passionate look when it comes from the family. And so I would suggest that keeping a stress level low and sharing it within the family makes it more appeasing and helps the caregiving to be more appealing and benefits the person who's getting the care. Just to add that, that's it. Thanks.
Dr. Abhijit, would you like to respond to what the others have been saying? Anything you would like to add or agree or disagree?
No, I absolutely agree, because caregiving has so many facets, and so many different. It could be long term, short term, and with hope, without hope, and so caregiving is not something which can be which just means that 1+1 is 2. It could mean 1+1 could be 11 as well. So caregiving has its own varied facets, and each facet is unique by itself. So, I would put it at that.
Uh, uh, Radhakrishna, anything you'd like to say?
Again, it's a wonderful topic, and so wonderfully dealt by Dr. Abhijit as expected. I have a couple of comments or just say questions. Caregiving in India, at least when I see in the corporate sector, is a very strange phenomenon. Most youngsters would like their parents to get hospitalized if there is anything like a caregiving is required. And because essentially caregiving is a lot to do with the management of the bowel, bladder, and food, etc. And then my question again to Dr. Abhijit Dam is that, aren't nurses the form the biggest chunk of caregivers in the world. And do they undergo all the trials and tribulations and stress of caregiving? Do they manifest any of those, or do they have any mechanism, or do all they require some special care and counsel? Nurses as caregivers.
See, nurses as caregivers are definitely, I mean, they are doing a marvelous job. They have been doing a marvelous job since so many years. But then, if you see the process of caregiving as such, the nursing curriculum does not focus exclusively on the whole facets of caregiving, right? So I took it upon myself to develop this course, which I basically developed as a nursing aid, palliative nursing aid. So basically, I developed this course to address the various facets of caregiving and self-care and compassion and mindfulness and certain social cultural aspects which need to be integrated within, so that the candidates who are being trained as caregivers could actually be perfect for what our country and our culture stands for. So it has to be something which is locally appropriate, culturally acceptable, you know. So that is what I attempted to do. So if you see the nursing curriculum, it doesn't focus totally on the process of caregiving for a bedridden. There are so many other facets if you see the nursing curriculum. But caregiving as such, I would call it a sort of a super speciality, right? So its varied facets have to be addressed exclusively. So this is my take on it.
Now, the second point is actually, quite often we see very old couples who keep tending to each other. If one person passes away, the other one doesn't live long. Exactly. I mean, what is the effect and what is the physiology behind?
See, as they say that the greatest loss which can happen to a person is the loss of his spouse in an elderly age. Because the spouse is your partner, throughout life, and be it ups and downs. And when there is a loss of the spouse at an elderly age, somehow there is a sense of loss of meaning and purpose in life, because then you keep on searching for meaning and purpose. And when you cannot come to terms with that suffering, because this is a suffering. See, there is impermanence all around. So we need to understand the nature of impermanence if we have to transcend this sort of suffering and loss. So understanding the nature of impermanence is by itself a great teaching. Unfortunately, most of us do not have the time or the patience or the inclination to understand such things unless it is thrust upon us. Like, we don't want to talk about death until it is right there at the doorstep staring at us. And then we suddenly are at a loss. We don't know what to do, how to deal with the process of death and dying. So suffering is something of that sort, suffering like a loss of a spouse, which you said. So it is the nature of impermanence which one has to get accustomed to. You need to accept it, and you cannot just accept it over a period of a day or a couple of days. It requires a lot of practice and training your mind, because training or taming your mind is an art by itself.
Ravi Shankar wants to make a comment. Yeah, Ravi?
Yeah, can you hear me?
Yeah.
Yeah, sorry. I was going to ask about a rather unique situation that seems to become more common in India these days, and that is where children live in countries other than where their parents are, parents in India, children elsewhere, and providing care for such groups is becoming very difficult. Are there any organizations or any groups that offer help in this situation?
The eastern part of India, because I live in the eastern part of India, we do get many such requests, but then you have to understand that what the children expect, the expectation of the children who are staying abroad, and the expectation of the parents who are, left alone in cities or in flats or whatever, they do not match. The children expect that their parents should be cared about, because this comes from a sense of guilt which the children develop once they are abroad. They feel that I am not doing my social duty. I'm not following the path of dharma, as I said. So this is where there is a imbalance, right? So talking to both the parties individually at most of the times helps resolve most of the issues. Of course, if the parents are totally physically incapable of looking after themselves, then there are so many alternatives, like, there could be long-term hospitalizations or certain elder long-term care facilities. I have started a long-term care facility in my hospice. So we have actually adopted an elderly couple also, that sort of thing. So, I mean, there are institutions which are actually coming up. In fact, there are so many institutions now at Kolkata which actually provide home healthcare facilities for long-term care as well. And they are quite expensive also, but they are doing a good job, no doubt. So these things are coming up, and in the coming years, we'll see a budding of such activities, flourishing.
Yeah, if I can add to that, Ravi, as rightly put by Dr. Abhijit, there are many such organizations, because now there are a lot of nursing students, especially auxiliary nurse midwives, have been trained without employment. Actually, they are being employed by this private nursing groups which cater to all that. In addition, there are a couple of some sort of hospice type centers, not exactly hospice, but people, elderly people being taken care of. You need to pay some money, and like this, they are there in Chennai as well.
We have Ravina, a young doctor whom I work with. Ravina, it's nice to see somebody young being interested in this subject. So, Ravina, go ahead, unmute yourself and say whatever you want to say. Unmute yourself.
Yeah, thank you so much, ma'am. And it's actually a very good topic where I really, it's like really mesmerizing, as before our senior consultant said about it. And truly to say, this is a very good topic to choose and talk about it. Now, the reason behind me raising the hand is I just wanted few advice from all my senior people who's here. The thing is, I am working as a duty medical officer in a hospital, and I normally see wards. And here I find there's so much of chronically ill patient, bedridden patient to be in the ward for more than 1 month, can be more than 20 days, and they get treated and they go home. But when after 1 week, I have a good connection with the patient, and I start thinking him as my grandfather, my brother, my sister, like that. And I started having that attachment. And when the prognosis of the treatment is not so good, or if I lose a patient at any point of time, I drop myself and I think for a week or two, oh my God, I lose that patient. What shall I do? What should I be done? Of course, yes, academically, I have learned so many things. And I also definitely agree with the point the neurologist sir said, that even the medical people are also a caregiver. So how do you all face this situation at my age and came forward to this place? And how was your caregiving capacity at that time? Just make myself little give me some tips and tricks so that it will help in my day-to-day activity. I just wanted that.
Dr. Abhijit, very valid point.
There are no tricks or tips in that. It is when you feel that you're ready, the path will open up for you. You need to understand the nature of impermanence, right? And to understand and actually believe, not only understand, but to believe in the nature of impermanence, you have to convince yourself, and that will take time. The time will come. You can't just make anything happen just like a snap. Everything has a time. Everything works out, because nothing happens by chance. Everything, the very fact that you're sitting and we are all talking together in this beautiful forum isn't just chance. It is something which has been destined to happen because I choose to believe in that. And so it's a choice, as I said. You have the power to choose to be saddened by somebody's loss, or you have the power to choose to be happy and to be grateful for the beautiful care and the beautiful time that you could give to your patients when they were hospitalized under your care. So it's a choice.
Yeah. I definitely agree with that point, sir. And yeah, at times I go really low, and I motivate myself that next time I should say my patient more well. But I just wanted to get your input also. So thank you so much, and thank you, Vidya ma'am, for giving me an opportunity. And Vasant sir was very good in his speech, and he's my consultant at my hospital. So nice to meet everyone here. Thank you.
The person who's logged in is Android Blue Droid. Would you like to say something? I don't have your name.
And also there's one Anandam who's raised her hand. Yeah, Anandam.
Okay, Anandam, you could go first. Anandam, were you trying to say something?
I wanted to tell this young doctor. I'm a doctor myself, and I'm almost 70. I was working abroad, and then I came back to India in Kerala, and I was working with an NGO in palliative care. So that has given me a lot of experience. But right from the beginning, she asked a question like, what is it that the youngsters need to know? I always tell the youngsters, treat the patient as a whole person, and not only the systems, like what is happening now with over specialities. I hope you can hear me.
Yeah, I can hear you, ma'am. I can get you.
Okay, I'm running I'm running a place called Raksha in Kerala, Trichy, where we do look after the older persons who don't have their children in India. Of course, it is a little expensive in the sense because we have to pay for our staff and things like that. But it's a great thing that I can help so many older people during this time when their children are all abroad and they're alone at home. We do a lot of home care services for them.
Thank you, Anandam, and
thank you, ma'am.
We've been here for about an hour and a half. If anyone has anything specific to say, any questions, you go ahead relating to today's topic. For other topics, I will put you in touch with the concerned people. If you need any medical advice or anything about any specific thing, please feel.
I have a question.
Yeah. Go ahead.
Yeah. Okay. Good evening, everybody. It was a real nice session we had. The question is about a batchmate of mine who has an autistic child. Now we are all of us are around 60 plus. Now his fear is what happens to the child after, because obviously the child will outlive the parents. Financially, they are well off. So somebody suggested that maybe there are better options in the United Kingdom for such people who can afford it. So this couple can certainly afford it. Is there any advice for such situations?
Anyone feel free to take up that question, because I really don't have an answer. And does anyone have an answer for this question?
I'll chip in, Vidya, and say that what this is Subrato speaking. I'll chip in and say, one of the things you learn about caregiving is not to find answers that are perfect. The answers change day to day as the needs change. So I guess it would depend on this person, what they want. There are so many options that are there, both in India and abroad, but that it's the biggest fear, your child has needs and you feel that your passing that person is not going to be supported. So I think the parents will be the ones who would best know the answers. What people can do is to help research and show them what resources are out there. And if I can just circle back to one thing Ravina brought up, I am young, what do I do? Is there a place to go to? Let me tell you the experiences from the Journal of Anecdotal Medicine, which is a great journal to quote from. 1984, I was 24 years old. I went to Chidambaram to do leprosy rehabilitation, and I spent some time there. And for the first time, this smart me who knew all the stuff out of Harrison and out of Davidson and out of Bailey and Love came face to face with reality. I saw suffering up close and personal. And the person who was teaching me was an extraordinarily gifted leprosy hand surgeon. I learned a lot of how to do stuff. What nobody taught me is how to emotionally distance from what I was seeing. I didn't have the maturity. So the answer I can tell you, Ravina, is this is part of growing up. It's learning to put things in perspective. Well, that's a great thing, but how do you go about it? I'll tell you what I found. I found mentors. I found people who had character, values, and a way of doing things in life that I looked and said, I am not that yet, but I can be that. And I looked at these mentors and I'd go to talk to them. What it amounted to was like therapy. It's like going to a psychotherapist, except that this person is not a psychotherapist. This is not just a friend. It is somebody, and it does not need to be in medicine, but it helps if they're in medicine because they understand what you're going through. It's somebody who kind of looks at you and says, it's like the compass. You don't know where the North Pole is, but there is something here in my hand that will show you the direction. This is the way I think you need to keep going. What it does is, one, you're able to actually put what you're feeling in words. You set a very good example. You have a chronic patient, you get close to them, and the outcome is not good. Either they have passed on or something, and you feel like you lost your own relative. If you have nobody to talk to, it builds up inside you like a pressure cooker.
Exactly.
To get a mentor is to actually be able to first you've gone outside of yourself to put everything in words and speak it out. And secondly, if you like and trust and want to emulate what your mentor is about, they can be your guiding lights. To give you a running example, you are the one who is running the race of your career. The mentors are like the water stations. You pick up a bottle of water, you refresh yourself just by coming in contact with them, and you continue down the journey. Right now, there is very little formal training that is there. And, each one of us is different. So I would recommend very strongly, find a mentor, find good mentors. If you don't feel that the mentor is somebody who is up to what you're wanting, go look for another one. And physical exercise to keep as fit as possible. The brain works best when your body is good. So that's what I do. I go out and I hit the gym every day. That's from the Journal of Anecdotal Medicine.
Yeah, thank you, Bhattacharya sir. It was amazing. Thank you so much for listening to my question and answering it so beautifully. I definitely take it. I journal it, all the point what you said. Thank you.
Yes, sir. Very, very well said, sir.
Vidya, can I just add on Dr. Sailesh's question?
Sure.
Yeah, he asked a very appropriate question. He said, if you're financially viable, what is the option? Now, let us put it into perspective. If you have a wheelchair-bound person in India, and if you have to move them around, it's not the same when you're going to Europe, or you're going to go to Canada, or go to US. So the facilities are there, which makes the person who's involved himself more comfortable. So all I would suggest him that, make sure that if your child if whoever is the person involved is financially available possible to get an immigration and go into a country where they are, where the care can be given, at least let the person who's suffering enjoy the benefit of that, rather than, I'm telling out a personal experience. Mobility and feeling the sense of self-confidence cannot be the same in every country. And this is for all people with lot of developmental problems and challenges. So that's what I was trying to say. The developmental challenges of a children and the developmental, the caregiving that's done for an elderly is totally different. So I'm not against what's happening in India, but India has still got a long way to go to look after these sort of children who need their level of freedom and to get, and the infrastructure and availability of lot of facilities, which has still got a long way to go. And I hope things will change. Even from Dubai, I'm looking at taking my son to Canada, because then that's got a much better, more freedom for him to be on a self-reliant and still continue on their own confidence. Caregivers can be there, but you have to keep your person who is being given the care also confident to have their life to continue on. So I would suggest that there's nothing wrong if you are financially viable to do whatever best it is. At least that person can enjoy the part of his life that he's got. Thanks.
So thank you.
Yes,
everybody.
absolutely, sir. Thank you. Thank you so much.
Thank you everybody for logging in today and for actively participating in the discussion. And like Radhakrishna said, Dr.Abhijit Dam delivered even more than what we expected. And thanks, Bata, for taking time off from your work to join us on a weekday in the morning hours. Thanks, Vasant, for bringing in the perspective of caregiving for psychiatric patients. And thank you all once again. And we'll see you again next Thursday with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.